This is Exercise Phys Lab 2 Spirometry component. This goes along with the heart rate and blood pressure components of this lab, depending on which order you watch it in. So we'll get moving here. This is what a typical sort of signal acquisition setup looks like in the lab, and I'll talk about the difference between clinical spirometry and sort of more lab-based spirometry in a minute. But this is what our setup looks like. This is you typically have like a rubber mouthpiece that you can sanitize using a high-level disinfectant for reuse. The person's lips go over it, so it's fully within their mouth, and you're not losing any air on the outskirts. And then the thing that's actually missing here is their nose piece to ensure that all the air entering and exiting their lungs goes through that mouthpiece. We attach a filter here just so we don't have to clean our flow head as often. This boring tube actually just creates some laminar flow of that air, and that's important because the way that we actually measure the flow of the air is with this thing called a flow head. So a pneumotachometer is a different way to refer to it, but it's essentially 3 little screens of different densities, and when air passes through each screen, we then pull, but the first screen laminarizes the flow of the air, meaning that it just sort of makes it very smooth and all moving in the same direction. Then what we do is we pull a small volume of air via this first plastic tube into a machine that then converts how much air is passing at a given point in time into a voltage. Then we compare that between the first and second screen to that same measurement between the second and third screen, and the difference in the partial pressure of those airs actually gives us our measure of flow. And then based on a calibration factor, we can take that at a flow at any specific point in time and then convert that to an actual real volume of air in liters. Then that's all collected into our signal acquisition unit, slightly filtered. So then we have 2 measurements. Like I said, we have our rate measurement and our volume-based measurement. So that's typically how we would measure that, and you'll see how we actually collect it in a second and what that looks like. But just going over that you should familiarize yourself with these terms. They're in your lab manual, but going through our volume-based measurements, you can see that tidal volume, inspiratory reserve volume, and expiratory reserve volume are all very common. Other ones we're going to look at are vital capacity, specifically forced vital capacity, where the person exhales everything they possibly can in their lungs, because these are more specific to pulmonary function tests. So I really want to touch on that we have some flow-based measures, specifically peak inspiratory and expiratory flow, but also we have some volume-based measures, which all the other ones are. I'll talk about the volume-based measures in a graph here in a second, and then when actually talking about the flow loop, I don't want to necessarily give too many things away, so I will let you guys look that up. There's a pretty good depiction of it anywhere sort of you Google it on Wikipedia or something. But other things we're going to look at here are forced vital capacity, so the total amount of air you can breathe out at any one point in your lungs, no time limit on that, but also forced expiratory volume in 1 second, or FEV1. That's how much air you can breathe out in 1 second. So same sort of protocol as forced vital capacity, but you're only taking that very first second of it in which most of the air is exhaled during that second. The last is the ratio. I forget the name of the authors who invented this ratio, but it's the percentage of your FEV1 over your FVC. So here's a graph, and it sort of gives a depiction, and this is volume-based. So these are all our volume-based measurements. So if we think of our total lung capacity as being this top blue dotted line to the bottom blue dotted line here, what we can then think is, okay, so if this is our total lung capacity in liters, and we know that there's a certain amount of air you can never breathe out, or else your lungs would be collapsing in on themselves and you wouldn't be able to reinflate them, being our reserve volume. In a typical person, that's anywhere, I think, around 500 milliliters, maybe a little bit more in a larger person. But if we have that reserve volume, then our vital capacity is our full inspiratory volume, so our lungs completely full, down to that reserve volume, and that's what that vital capacity arrow shows. Regular tidal breathing, or the volume of tidal breathing, is shown here as the person regularly breathes these small fluctuations, so they're not going anywhere near their full full inflated lungs, or their lungs as deflated as they will allow physiologically. But with then that difference between our normal tidal breathing and our full inspiration or full lungs is that inspiratory reserve volume, and the difference between a regular exhalation and that borderline between regular reserve volume is our expiratory reserve volume. Then we can look at our forced vital capacity here. So again, we get the person breathe all the way in and then exhale completely. So we have our vital capacity, and forced vital capacity is simply them doing it as fast as possible, the entire thing, forcing it out, whereas regular vital capacity is more of a sort of slow, sort of theoretical thing, and in practice in a pulmonary function test they would be doing a forced vital capacity. Okay, so here's a little video on the spirometry in the lab and how we would do it. I'll just sort of talk over this, but I'll let the audio play in the background so you can kind of hear us coaching the person through it. And this one is going to be that signal-based acquisition, which I talked about before, and you're going to see a graph come up here. We did a little screen record, so the graph on the top is going to be our rate, so typically what would be measured in liters per second, and that's sort of what I described as the pneumotac or the flow head measuring normally. And on the bottom in blue we have our volumes, so that will more resemble the graph we just talked about. Ian just performed an FVC there. And then you would, if you wanted your FEV1, you could take your measurement from the very beginning of that exhale to the 1 second mark. Okay, so now that we have the person doing regular tidal breathing, typically you get the person to tidal breathe for about a minute in between FVCs or FEV1 attempts. I'll then coach him now for this next one, and I'll sort of go quiet so you guys can hear what that sounds like. Okay, can I get a big exhale? Go, 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 go. Keep going, keep going, keep going, keep going, keep going. Go, 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 go. And inhale. There you go. So you can sort of hear me coaching him along. Okay, I want you to breathe all the way in. Breathe all the way in. There you go. And then big forced exhale. For a minute, and then go, 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 go. You do your best midwife impression. Tell the person to push all that air out of their lungs, and that's essentially how you would coach them through doing an FEC. If they're at all slow or they seem like they're not inhaling all the way, that's when you really sort of take a step back and coach them through it. Again, they should be expiring for a good 5 seconds after they feel like they have nothing left. You can see at the bottom of the graph there as it runs, his rate of expiration really slows, almost to the point where
push, 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 keep going, keep going, keep going, keep going, keep going, keep going, and inhale.
And really coach them that they only inhale when you tell them to inhale, or they absolutely can't. I mean, they will naturally do it when they have no air left in their lungs. So just tell them that they are only allowed to inhale when you tell them to do so. Keep coaching them. Exhale, exhale, go, 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 go. You can hear a fire truck on Spadina. Okay, so this is what a spirometry in the clinic would look like. Again, it's very different, the setup. You're not displaying the live signals to the person. Okay, I just waited for the fire trucks to go by there. So this is what spirometry will look like in the clinic. We use a slightly different setup, which I'll talk through here, but is more based on those pulmonary function tests, and that's really what the display gives you. It doesn't give you those raw signals separated into volume and flow. Really, it just gives you the flow loop, because so much of what we're looking at is dependent on flow. So it gives you the shape of that flow loop. I've zoomed in a little bit on the software here because it doesn't go full screen. So really it just displays the full flow loop, and you'll see in here, and he'll give big inhale, exhale.
Push, push, push. Keep going, keep going, keep going until it's green. Keep going, keep going, keep going, keep going, keep going. And
so it shows the volume very quickly there. It also counts the person down. See how it goes red, yellow, green. So it counts them in for like a full 5 seconds to wait for their full FVC here. Yellow, and then it gives them a beep when they can inhale. So that's what a typical handheld spirometer for a pulmonary function test would look like. This one's hooked up to a computer. Some have a digital screen on them. And that's what it should sound like. That's what it sounds like when someone's giving it their all, that exasperated breathing at the end of it. And I wanted to mic him up to make sure that he saw that. This one takes 3, averages it, and then shows you the flow loop after. So I'll just pause this for a second because we can look at our data here. And really what you're looking at is it's giving you that flow loop, and then it's giving you your PT and PF, and then your FEC and FEV1. Really, those are the 4 numbers that we're going to be looking at. Also the FEV1 to FEC ratio. And then it displays all those numbers immediately for you. There's no clicking between like we would have to on the signal based one. We would have to do some calculations and look at different points in time. This the algorithm sort of picks those up and picks out those data points directly for you and displays them. So it's super nice and super easy to use. And again, this is one hooks up to a computer. There are others which are completely handheld, and those are a little expensive. I think anyway, like let's say this one's $1,000 and those are $5,000 to get the screen on them and a data logger, but I think it's well worth it. And this is typically what you would see in a hospital or lung function testing center. So looking at looking at the data a little bit clearer, you can see that while Ian's FVC was 4.2 liters here, his FEV1 was 3.52, and the ratio of that was 83%. So I believe the cutoff for a COPD or something like that is sub 75% or 70%. So that gives you a good indication that he does not have obstructive pulmonary disease. I think Ian does have slight asthma. So it's a little low there, but not completely low at all into a sort of clinical diagnosis level. That's sort of how you would read that data report, and that's it for spirometry.